So I am here to talk about sickle cell disease. I am Dr. Julie Cantor from the University of Alabama at Birmingham, and I'm really excited to tell you about all the new great things happening in sickle cell. It is the most common inherited blood disorder in the United States. We know it affects up to 100,000 individuals, and that 1 out of every 365 Black or African Americans will be born with sickle cell disease. We also know it's very expensive, accounting for up to $75 million a year in costs. We also know there are more adults living with sickle cell disease than ever before. Thanks to improvements in pediatrics, newborn screening, and improvements in stroke prevention, we are seeing more adults living into adulthood. However, the average life expectancy is still 30 years shorter than those without sickle cell disease. Individuals affected by this disease have a very high rate of returning to the hospital, an increased risk of stroke, and not enough support, advocacy, or financial support to improve outcomes. We've known about this disease for over 100 years, but there's only been one drug that was approved until recently. Otherwise, we've had opiates, fluids, and blood transfusions, which is truly not enough. Again, you can see the significant improvements here in childhood survival in all genotypes, but we're still seeing this peak noted on that red curve in mortality, especially in Georgia and California, where we have the best data, and people are dying in their 40s. Now the good news. There's an increased understanding of the pathophysiology, and we have new targets, new knowledge, and new outcomes to move forward and improve our outcomes in sickle cell disease. The old view of this disease was completely limited to the genetics. We know it's a single mutation that causes the sickle gene, the sickle hemoglobin, and we thought everything was the red cell. Hemoglobin S polymerization led to viscosity and hemolysis. And you can see here that we thought everything was caused by that hemolysis, and then on the other side, the vaso-occlusion, where the red cells were getting stuck and not able to flow through the microcapillaries. While this does contribute to many of the complications that we see, we know that there's more than just that. The red cells themselves have an abnormal cell membrane, and even when they're not sickled, there's an abnormal interaction which makes these cells stickier, and it increases adhesion to the endothelium because of this abnormal cell membrane. The endothelium itself plays a pivotal role in regulating blood flow. It helps with fluid filtration, it changes the way our blood vessels work, and it also helps or hurts with neutrophil recruitment. So every time there's a crisis, we're impacting that endothelium. You can see here the significant areas in which sickle cell disease affects the endothelium and different targets that we're actually looking at to improve our outcomes in sickle cell, through fetal hemoglobin induction, through blocking that adhesion of the sickled and neutrophils to the endothelium. Pain is still the hallmark feature of this disease and the primary reason for which individuals seek care, but not all individuals with sickle cell disease have pain, and in fact, it can be a red herring for other problems that are going on with these individuals. There are multiple organ complications in sickle cell disease. We obviously don't have time to review them all today, but there is not an organ that is not affected by this disease, because every disease has blood vessels, and blood vessels are the target organ in sickle cell disease due to the endothelial damage. Again, these new targets, we understand now how much the endothelium and the neutrophil play a role in this disease, and these are just some of the new drugs being developed that have specific targets. So instead of just the red cell as a target, we know that we can actually target the endothelium. These new targeted red cell therapies, in addition to endothelial targeted therapies, will allow for multimodality treatment in the future, hopefully combined with anti-inflammatory therapy and perhaps antiplatelet therapies to really target this disease from all angles. We're also working on new curative therapies. We know stem cell transplant is a cure, but we also know that not everybody has a donor. So we're studying alternative donors and non-myeloablative therapies, as well as gene addition and editing therapies. This schematic shows the different ways in which we're looking to use stem cells as treatments in sickle cell disease. We're looking at allogeneic transplants, both matched-SIBD and haplo. We're looking at gene addition therapy, where we can add a healthy hemoglobin to the gene, or gene editing. There are still barriers in care to sickle cell disease. Healthcare access may dictate whether or not you get a specialist, and that is important if you want to improve your outcome. We don't have enough biomarkers or patient-reported outcomes. We also need to make sure that all patients get the care they need, and that in studies that are successful, we disseminate and implement that information. We are also trying to train new doctors to improve their care for sickle cell patients and to become sickle cell hematologists. So I'm excited. There's new knowledge about who has sickle cell, where people live, but also why they're still dying too young. We know more about the pathophysiology. We have more targets. We understand the barriers, and we have lots of ways in which ASH and the community are working to increase dissemination and implementation.